Okay, so today we're going to talk about these two terms, pulmonary ventilation and alveolar ventilation. All right, so there's a lot of interesting information on this slide to begin with, okay? Basically, when we talk about pulmonary ventilation, that's just the amount of air that we're going to move in and out of our lungs. Okay, so as you're breathing, as you're all sitting there taking notes, all right, your pulmonary ventilation is occurring, okay? And we're going to measure this in a period of 1 minute. All right, just like when we do heart rate and all that, all right, everything's based on 1 minute, 60 seconds. So we already talked about what tidal volume is, okay? So your tidal volume is going to be the amount of air that you breathe in, all right, and breathe out, okay? So on average, that's about 500 milliliters, okay? Then a respiration rate, obviously, is going to be the number of breaths per minute, which is about 12 to 15, all right, 12 to 15. So when we're trying to figure out what our pulmonary ventilation, that's the amount of air that we're breathing in and out for 1 minute, you're just going to multiply those two numbers together. You're going to multiply the volume, tidal volume, by the rate, all right, which is going to be in time in increments, breaths over time, okay? So on average, if you're breathing a normal respiration rate, you're going to breathe in and out about 6 liters of air per minute, okay? So you should be able to calculate out, all right, this, all right, this equation here, okay? Tidal volume times respiration rate will equal your pulmonary ventilation, pulmonary lungs, so the amount of air that's moved in and out of the lungs. All right, so we're going to talk about, all right, some other regions of the respiratory system, all right? Now, when we were going through lab, we talked about how, all right, you have a conducting zone and a respiratory zone. All right, so the conducting zone is basically where air is going to move in, all right, through these pipes, and it's going to get funneled or transferred down to the respiration zone, in which you're going to have the exchange of respiratory gases. Okay, so the conducting zone anatomically is much larger than the respiration zone. Okay, so that leads me into anatomic dead space. All right, this is all that space, all right, measured in volume, all right, where there's no gas exchange going on. That's the conducting zone, okay? So that is going to be, you need to know this value, it's about 150 milliliters. That's the anatomical dead space, or anatomic dead space. There's no exchange of gases here, okay? It's all the piping, all right? Mouth, throat, trachea, bronchioles, all that. That's the conducting zone. Okay. All right. Now we're going to talk about alveolar ventilation. All right. This is what's going to occur, all right, in the alveoli. And so how much air do we get in the alveoli per minute? All right. So what we're going to do now is we're going to take the tidal volume, all right, which is about 500 milliliters. We're going to subtract the anatomic dead space from that value, which we just learned. It's 150 milliliters. All right, that gives us 350 milliliters. All right, we're going to multiply that by the respiration rate of 12 breaths per minute, and that gives us 4.2 liters per minute. Okay, so out of that 6 liters of air that is entering our lungs, 4.2 liters makes it into the respiration zone. Okay, where we're going to actually see the exchange of gases there. All right, so obviously, if you take a deeper breath in, you're going to increase your tidal volume. And if you take a deeper breath out, you will increase the tidal volume. So if we increase the tidal volume, all right, then the value here, if our anatomical or anatomic dead space does not change, all right, if our tidal volume goes up to 700, let's make it easy, 750. Okay, and we subtract 150 for the anatomic dead space, that's going to be 600. 600 times 12 is 32. So, no, I'm off. Jeez Louise. So is it 4.4? Is that what you said? 6 times 12. Oh, Lord. Yeah. All right, so 7.2 liters. Did I do that right? That seems high. Okay, all right. Anyways, I was never great at math, all right, except when it came to money. I like to count money. All right, so keep that in mind. So it makes sense, right? Breathing in is going to increase that alveolar ventilation when we take our deep breaths. All right, so far so good. Okay, so that's the anatomic dead space. Now, another term that we need to throw in there is physiologic dead space. Okay, now what we're going to take our normal anatomic dead space, and then we're going to add any alveoli that we have lost through the natural aging process, let's say, or if unfortunately you were afflicted with a pulmonary condition like pneumonia, okay, pulmonary fibrosis, emphysema, whatever, okay? All right, so something is going to cause the loss of alveoli. So we'll just add those two together, and that will give us our physiologic dead space. All right, these are things that you need to keep in mind. So some of those disorders will occur, which could damage the alveoli, and we all know that's where we get our gas exchange. So therefore, we're going to have a compromised exchange rate and exchange amount of gas going on in the alveoli. All right, so pneumonia is an example. Pulmonary fibrosis, I said that. Not so much asthma, but emphysema. Okay. So, and all of us, I'm going to assume that we're all healthy individuals. We will have very little physiological dead space, if any. All right. When we're talking about like any of us, for example, we pretty much assume, as long as your medical history is clear, that you will not have any physiological dead space. Okay. Unless you're lying to me. Okay. So, do you feel pretty good on pulmonary ventilation and alveolar ventilation? Because now, if we go back, all right, to, let me go back to, I'll come back to that later. I'll bring up that those practice test questions here in a second. All right, let's climb into volume and capacity. Okay, has anyone ever done a spirometer test before? You have? All right, I had to. I used to do asthma research as a guinea pig, so they paid well. You know, you can make some pretty good money. And you got to try all these some were new drugs, and some were drugs where they were just messing around with dosages just to see, all right, this dose worked. How about if we increase it to this amount? You know, it's a double-blind study. You go in there, you get paid well, and you get free Ventolin, you know, so rescue inhalers. So I was like, wow, why not? So, anyways, you have to do the spirometer tests, all right, before you get into the test, during the test, and then after the test. So it's going to basically measure how healthy your lungs are, your respiratory system, mainly the lungs, okay? So there are 4 volumes, and pay attention because we're going to get into capacity after volumes, all right? There are 4 volumes that the spirometer measures. All right, the first one, tidal volume, we're familiar with that, okay? Amount of air coming in and out, all right, during our normal eupnic breathing as we're all sitting here. Okay, this is what we are breathing in and out. Okay, now if I were to take a deep breath in, all right, and I'm being measured on a spirometer, then we're going to be measuring the inspiratory or reserve volume. Okay, and this is going to be, when we take a deep breath in, the amount of air that flows into your lungs with a forcible inhalation. Okay, now if you don't remember what compliance is, all right, compliance is the ability of how well your chest wall can expand, okay? How well it's able to move, all right? How well the lungs can expand also, okay? Kind of like how springy your lungs are, well, mainly the chest wall, okay? So that's what we're talking about when we talk about the inspiratory reserve volume. We're going to measure, all right, the compliance, how well, all right, your chest wall can expand. Okay, so now I'm going to ask you to take a deep breath out, all right, and that's going to be the expiratory reserve volume here, and that's a forcible exhale, okay? This measures the elasticity. Remember, those alveoli are loaded with elastic fibers, okay? So certain conditions can destroy the elasticity. Age is one of them, All right, so as you get older, your ERV will decrease, okay, because your elastic fiber numbers decrease over time. All right, emphysema is another thing that can cause an issue with the ERV because emphysema, it will destroy those elastic fibers. We'll talk more about that in a second. So after I force that breath out, I push it out as hard as I can, you still have air in your lungs, okay? And that is the residual volume. That's the remaining amount of air. It's not very much, all right, but you still have air left in the lungs, okay? Now, someone asked once when I was actually taking a physiology course, what happens if you get the wind knocked out of you, okay? So I don't know if you've ever had that, if you've fallen on your back and you can't breathe, you know, okay? That's when you will force out a lot of that reserve volume, all right? But as far as they know, I mean, this is, again, all academic and theoretical. It's virtually impossible to have no air in your lungs unless you're in the vacuum of space, all right? It gets sucked out of you, all right? Then you got other problems to worry about, okay? Other than just the air leaving you. Which I got into a topic. Did I ever tell you guys how I want to be buried? I want to be blasted into space. And I was going to say nursing homes. There's actually funeral homes that will arrange it where you can have your remains put into space. And it's only about $10,000.
Only.
Well, I say only, but I mean most insurance, if you do a life insurance policy, well, I said, and it's not like your body. They cremate you and then they blast you into space. But I want to have my actual body put into space. Hopefully I don't know, maybe, but I'll be dead, so what do I care, you know? But I'm hoping that an alien civilization will find my body floating through space and reanimate me. Kind of like Jason X. Has anyone ever seen Jason X? Remember the Friday the 13th movies? Oh, if you want to laugh, have you seen that movie? Oh, it was, oh, yeah, that's right. You're a lot younger than me. Oh, I thought it was funny. I came home one night and I flipped it on, and it was such a bad movie, you know, but it was actually kind of funny. But anyways.
Come up with some more ways to
Kill people?
no, dispose of them.
Oh, yeah. Well, if you want to find a way that no one would like, if you ever watched the movie Soylent Green, is anyone familiar with that movie? Soylent Green? Oh, Google it sometime. You would think. You would really think that I do. But
Crowd's not in here anymore.
yeah, that's true. But anyways, okay. So we did the volumes. We talked about the 4 volumes. Now we're going to talk about the capacities, okay? And basically, capacities are when we take some calculations from those previous volumes that we just discussed, all right? And they're going to give us, all right, these values here, or these capacities. So the inspiratory capacity is when we add your tidal volume plus that inspiratory reserve volume, all right? So here, let me show you on this little graph here. Okay, so here, right here, these little, all right, during normal eupnic, all right, or quiet breathing, here you can see on the spirometer, all right, this is going to be, all right, the normal amount of volume of air that you're breathing in and out, okay? So when at the top here of tidal volume, okay, that's tidal volume. At the top, when you take a deep breath in, all right, this big line here, all right, the distance from the top of the tidal volume, when you've taken a breath in, all the way up to the maximum amount that you're able to inhale, all right, that is the inspiratory capacity, or excuse me, the inspiratory reserve volume, all right, is going to be from the top of your tidal volume up to the maximum amount that you're able to inhale. When we add those two values together, tidal volume and the inspiratory reserve volume, that's going to give us our inspiratory capacity. How much air you can take into your lungs, all right, with a deep breath. If you start at an exhale, okay, so if I just exhaled up, now if I take a deep breath in, all right, that's going to be my inspiratory capacity. How much I can take in through tidal volume and through that additional deep breath, the inspiratory reserve volume, okay? All right, next is our functional residual capacity, okay? Now, I've taken a deep breath in and I start to blow it out, okay? So what the functional residual capacity is going to measure, all right, this is going to measure when I take a nice deep breath out, all right, when I force it out, all right, and how much air is left in my lungs, Okay, so basically this value is, all right, I take a breath in, I take a breath out, and then I just say, all right, keep blowing out, all right? And this will actually measure, let me go back to this graph here, okay, that functional reserve capacity. I don't know if you can see it very well. Zoom in a little bit. All right, so here I've taken my breath out, all right, and then I just keep forcing it out and blowing out, all right? Now again, you can't get much more. There's always going to be air left in your lungs, all right? So the remaining amount of air, all right, that will be left in your lungs is the residual volume. So we're going to add the expiratory reserve volume together to the residual volume, and that'll give us our functional residual capacity, which is the amount of air, all right, that's in your lungs after taking a quiet breath out, okay? All right, vital capacity, this is a very important number, all right? This is when we are going to see how much air moves through your lungs, all right, with a big deep breath in and a big deep breath out, okay? So this is what we're going to see when you have to force your breathing. And if you have done a spirometer, when you have to do all this stuff, it's crazy, because especially this last part when we get into, well, that's on the next page. I'll get to that in a second. All right, so vital capacity, they'll actually measure it a couple times. So you actually have to take a deep breath in and a deep breath out, and sometimes you get lightheaded when you do it. And then finally, our last value here is going to be the total lung capacity. All right, so we're going to add up all of these values. It's going to be the maximum amount of air that can move into your lungs. And what did we say during that time? It's normally 6 liters. Okay, 6 liters with normal breathing, healthy lungs. Okay, with our anatomical dead space and whatnot. All right, that brings me to forced expiratory volume, FEV. All right, and there's two different. We'll talk about FEV1. Okay, FEV1 is based on, all right, the amount of air that you blow out in 1 second. Then there's FEV2, and that's the amount of air that you blow out in 2 seconds. Okay, but this basically is going to measure how much air that you're able to blow out. All right, when you're asked to, on command, blow it out. So this number should float around 75 to 85%. For folks that have issues, all right, with elastic performance of the alveoli, perfect example, older patients or folks with emphysema, that value will be lower, okay? Because the alveoli cannot collapse, I shouldn't say collapse, I shouldn't be using that word, cannot return down to their normal configuration, okay? It's harder for them to get the air out of the alveolar sac. So this number will be much lower here, okay? And then finally, our last value, the maximum voluntary ventilation. All right, this is when they ask you, and this is the worst one, I think, in my mind. For 1 minute, they're going to ask you to breathe as deep as possible and force it out as hard as you can, okay? And so we'll see over that period of time, as long as you have about normal, healthy lungs and your value is about 6 liters, all right, on regular breathing per minute, all right, this value will be as high as 30 liters. So you can move 30 liters of air through your lungs in a healthy individual, all right, when you do the maximum voluntary ventilation. Just forceful breaths in and forceful breaths out, okay? And so that's kind of like what we're going to see here, all right, on this chart here. All right, here's your vital capacity. We're including your deep breath in and your deep breath out and the tidal volume, okay? And then when we're measuring the total lung capacity, all you're going to basically do is take just that remaining amount, that residual volume, and add it to the vital capacity, and that gives you your total lung capacity, which is in there. Okay, let's get into some of our gas exchange principles here. What's the most abundant gas in the atmosphere? Does anyone know? Anyone know? Would you believe me if I said it was nitrogen? Nitrogen gas, 78% of the atmosphere in this room outside is nitrogen. Oxygen is second, all right? And then, believe it or not, give me a second here. Argon. You know, argon, really? Yeah. And then there's a bunch of other gases in there. Helium, krypton, which I thought was pretty interesting, hydrogen, water vapor, and carbon dioxide, obviously, is thrown in there, and methane gas. So those are just all, when I say the common gases, the most abundant gases that you're going to be experiencing, okay, in the atmosphere. So we listed the real popular ones here down at the bottom of the page, but there's only going to be two that you really need to be really focusing on, and that's going to be oxygen and carbon dioxide. But I have to mention nitrogen because it's the most abundant gas. 78% of the gas in this room is nitrogen gas, okay? So we're going to deal with two concepts tonight, partial pressure, right, and Dalton's Law. So that whole time in the previous parts of this chapter, you saw me referring to oxygen, but it had a P in front of it. Now we're going to talk about what that P represents. And basically, all right, when we talk about the partial pressure of oxygen, the partial pressure of carbon dioxide, all right, it is going to be the pressure that these gases are exerting when they're in a mixture with other gases. So in this room, okay, we talk about the partial pressure of oxygen. The partial pressure of oxygen is the amount of pressure that it's exerting on everything, all right, and the other gases that are mixed into this room. Same with nitrogen, same with carbon dioxide, helium, all those other gases that I mentioned, all right? So we measure that in mercury, millimeters of mercury, okay? So when you see, all right, this value here, when we're talking about PO2, we're talking about the partial pressure of oxygen, all right? And so when we're dealing with partial pressures of anything, okay, we're dealing with pressure, all right, we talked about this last class, all right, we'll deal with pressure gradients. And we're already familiar with that concept of pressure gradients. That means you're going to have, all right, pressure in two areas, okay? One area is going to have it higher, and the other one's going to have it lower. And we all know that the area that has it higher, where the pressure is higher, it's going to diffuse, or I shouldn't say diffuse, it's going to move from an area of high pressure to low pressure. And that's what we're going to see here, all right? So that gas is going to move down its pressure gradient, okay? Which is good because we're going to see that when we start to talk about how gases move across the alveoli into the pulmonary capillary, and then how gases move from the tissues into the blood, okay? So we're going to discuss all that. So keep in mind, all right, our atmospheric pressure is always going to be 760, all right? I know it's at sea level, but for all of our examples, all right, we're pretty much, unless you're otherwise told what the atmospheric pressure is, assume that it's always going to be 760, okay? So when we add up all of these gases, right, and all the other gases that are in the atmosphere here, okay, all their partial pressures should add up to 760, okay? And I'll show you how we're going to do that here. All right. So basically what we're going to do is we take the total pressure, all right, which is going to be 760 millimeters of mercury, all right, and then whatever that percentage of that gas is in the atmosphere. So I just told you that nitrogen is 78.6. So we're going to multiply 760 millimeters of mercury times that percentage of nitrogen gas, all right, and that will give us the partial pressure, all right, of nitrogen. See how we did that? All right. Just for fun, if we were, nope, I don't know why that's doing that. Again, you know I'm horrible with math. So I'm going to pull up my calculator here, and is it listed up there? Oh, jeez. I accidentally called somebody. My bad. Okay. So 760 millimeters of mercury times, let's do it for oxygen. Oxygen's roughly about 20.8%, I want to say. All right? So 760 times, oh, that'd be 0.208. 0.208 is equal to 158 millimeters of mercury, all right, roughly. Okay, so that's going to be the partial pressure of oxygen, like in the room, all right, at sea level, okay? So keep that in mind. So all we're going to do is, if you want to find out what the partial pressures are going to be, all right, you take the total pressure of gas, which is 760, and then just multiply it by the percentage of that gas in the atmosphere, okay? And then if you were to take all the partial pressures of all those gases in the atmosphere and add them up, they should equal this value here, okay? And that's what Dalton Law talks about. The total pressure, right, in a mixture of gases, so the atmosphere, is going to be the sum of all those partial pressures. That's it. Now you know Dalton's Law. Okay? We're just going to add up all the different partial pressures there. Okay? So this is all reviewed right here with the partial pressure gradients. Okay? We know, all right, that we're dealing with the pressure gradient. Okay? That something that's in a high area pressure is going to move down into a lower area pressure. And that's the same here when we're dealing with partial pressure. Okay, so we go from an area of gas that has higher in one region to an area where it's lower. We're going to see how that moves through the respiratory system here. Okay, so this right here, this concept is a big review. Gas moves from one region of higher partial pressure to a region of lower partial pressure until it becomes equal. That's equilibrium. That's I won't say homeostasis, all right, but that's equilibrium. Okay. Nature loves equilibrium, loves balance, which we're always trying to do here, okay? So we're going to see, all right, how these gradients operate in the alveoli, right, when they go from the air inside the alveola into the pulmonary capillaries. We're going to see how that works, dealing with partial pressures. And then we're going to see how it works, all right, in the systemic gas exchange, all right? So when those gases now start circulating in the blood and how they're able to move from the blood into the tissues. And it's going to be so easy. You guys are going to be like, Dr. Kaz, you're insulting my intelligence because you understand this concept. I'm telling you. And when I show you the picture, you're going to be like, that's easy. All right? So we'll get there. All right. So let's talk about, all right, how this works in our body here. Okay? So a couple of things that you have to understand, and actually this should not be a bullet point, okay? This should say air from the environment mixes with the air remaining in the anatomic dead space, okay? So the air in our alveoli is going to be different than the air in this room. Think about it. When you're breathing the air in, a couple things are happening. One, you're warming the air up. You're humidifying it, so what's that mean? I'm going to be adding water vapor to it, okay? So the water vapor, therefore, will change the partial pressure, okay? So a lot of changes. Basically, what I'm saying is the air, once it gets its way all the way down in the alveoli, it's different. So I don't even know you anymore, air. You've changed. Well, that's right, because it went through your mouth and nose and down into your lungs. And so it's gone through a lot of stuff during that time. So that's what we're going to see here. All right, but what we will see is that oxygen is going to leave the alveoli and it's going to go into the blood. That's how it's set up, and we'll talk about that specifically, how that works. So the general rule is oxygen goes from the alveoli into the blood, and carbon dioxide does the opposite. It goes from the blood into the alveoli so you can exhale it out. Okay, we know this, right? You feel pretty good about that? Okay, cool. All right, so keep in mind, all right, when we talk about the alveoli, we're going to see, all right, that the partial pressure of oxygen will be lower than the partial pressure of oxygen in this room. Okay? Remember, what was that value I gave you for the partial pressure of oxygen? 158? Yeah, 158 in the atmosphere. All right? In your alveoli, it's going to be more like 100. Okay? So it's different. Okay? And so we'll see also with carbon dioxide, all right, the partial pressure of carbon dioxide is going to be actually higher, all right, in the alveoli than it is in the atmosphere. All right, and we want to have that, okay? All right, so keep in mind, all right, when we're dealing with the alveoli, all right, they will normally stay constant. A lot of things we need to keep in mind that I'll tell you when things won't be constant, and we're going to hit that in a second here. All right, but in the alveoli, all right, these partial pressures for at least our respiratory gases, oxygen and carbon dioxide, will stay constant. Okay, will stay constant. It won't be different every time you go over it, and I'll tell you what I mean here in a second. All right, so now That's in the alveoli. Let's go to the tissues, to the cells. All right. Now we're going to see, all right, the partial pressure, all right, of these gases are going to be different, all right, in the cells for obvious reasons. But think about this too. When the cells are undergoing cellular respiration for any type of activity, for example, okay, what do you think is going to happen? The oxygen requirement is going to increase. We're going to need more oxygen because, again, what do we need oxygen for? For cellular respiration, to make ATP. Mitochondria want it to make ATP, all right? And so as a result, one of our waste products is carbon dioxide, okay? So the demand for oxygen increases, but the amount of carbon dioxide will also increase, all right? Because we use up more oxygen, we'll create more carbon dioxide, all right? So I'll explain this to you. So what we're going to see here, all right, in the tissues, in the systemic cells, all right, O2 will be lower, okay? And I'll show you in a picture why, okay? Will be lower than what we see in the alveoli, all right? And carbon dioxide will be higher than what we see in the alveoli. Well, that makes sense for the carbon dioxide because think about it. It's the cells that are making the carbon dioxide. All right, they're producing a lot of this carbon dioxide because they keep using up the oxygen, okay? So again, we're going to say under normal resting conditions, these pressures will remain constant, okay? So far, the partial pressures of oxygen and carbon dioxide are going to stay constant in the alveoli, and the partial pressures for oxygen and carbon dioxide are going to stay constant, all right, in the systemic tissues. All right, so what's the big deal, Dr. Kos? Well, now I'm going to tell you when it's not constant, and it's going to be here in the blood. All right, as the blood circulates throughout the body, carbon dioxide and oxygen, all right, those partial pressures will change. They will not be constant. But if you think about it, that kind of makes sense, right? The partial pressure of oxygen is going to be really high when that blood leaves the lungs. Because it just got refreshed. You just got all this new oxygen. Then it's got to start circulating through the body. So this tissue might need some oxygen. This tissue over here needs oxygen. So what's taking it? It's decreasing the partial pressure of oxygen. So by the time it gets back to the lungs, it's pretty low. All right? So that's what we're talking about here, that the partial pressure of these gases when in circulating blood is going to change. Okay? It's going to decrease. Okay, it can go from 104 millimeters of mercury in the lungs, and then say it goes to some of the tissue in the chest, which is close by. So it might be 68. All right, by the time it gets down to the toe, it could be 40 millimeters of mercury in the toe. Okay, you see what I'm saying? It's circulating throughout the body. All right, we're going to start just taking off that oxygen. But, all right, carbon dioxide, different story. Okay, that's going to increase. All right, we'll get into that. So this picture here, and I'm not going to spend too much time on this because I'll go into more detail on this one. All right, here you can see, remember we have two circulatory systems in our body. You've got the pulmonary circulation, the heart pumping the blood to the lungs, oxygenating the lungs, or oxygenating the blood and then sending it back to the heart. That's the pulmonary circulation. Then we have the systemic circulation. Heart pumps the blood out to the body, okay? So in the lungs here, in the pulmonary circulation, here's the alveolus, all right, here's the pulmonary capillary. Look at the partial pressure in the alveolus, 104 millimeters of mercury. Okay? Look at the partial pressure of oxygen in the capillary. What's that number? 40. So which direction, when we're dealing with pressure gradients, does the oxygen want to move to? Where does it want to go? Does it want to go from the lung into the blood or from the blood into the lung? That's right. Look, there's an arrow to help you out. See that red arrow? See, oxygen is leaving. Because look, higher partial pressure in the lung, lower partial pressure in the blood. It's that simple, y'all. It's that easy. All right? And this facilitates the movement. And guess what? We've only got technically 2 cells to go through and a fused basement membrane. That's one of the thinnest possible barriers in our body. So oxygen can diffuse right across. As long as we have that difference there, 104 to 40. Okay? It's going to stay constant here. This is good. This is the value. All right, so the partial pressure of oxygen will always be 104 millimeters of mercury. Okay, I'll go into more detail on this. Now look here in the blood. All right, look at the partial pressure of carbon dioxide. 40, all right, millimeters of mercury in the blood. What is it in, oh wait, I'm at the wrong spot. Here we go, sorry. 45 millimeters of carbon dioxide, right, is the partial pressure in the blood, and then 40 in the lungs. So where is it higher? Lungs or in the blood? It's higher in the blood, lower in the lungs. So where's it going to go? It's going to cross over. See that? You guys cool with that? Not too bad? Okay. Swing down here to the tissues now. Okay. Look here. Partial pressure of oxygen is 95 millimeters of mercury in the blood. All right. What is it in the tissues? 40. Where does it want to go? Into the tissue. Makes sense, right? We want to get that oxygen in the tissues. Okay. So it's going to diffuse into the tissues. Now, if we look here, all right, the partial pressure of carbon dioxide in our blood is 40 millimeters of mercury. What is it in the tissues? It's 45. Carbon dioxide will move from the tissues into the blood. All right, we'll get into more detail about that. All right, but you kind of see what I'm talking about? And these values will be constant. They're not going to change. But you did see, all right, look here. Look at the partial pressure here of the blood for oxygen, all right, and for carbon dioxide. All right, 104 for oxygen, 40 for carbon dioxide, right? Okay, look at oxygen now. It changed. It's not constant. Okay, it fluctuates. See that? Okay, we'll get into more detail. Trust me. If you don't see it, you will. All right, we got another law for you, Henry's law. Okay, this talks about, all right, how well we're going to take an actual gas. Remember, there's 3 phases of matter, right? Solid, liquid, gas. 3 phases of matter. Okay. So in this situation, we're dealing with a gas, all right, but we've got to get a gas into a liquid, okay? And nope, I don't see anybody drinking a Coke, all right? I was going to say, how do you think we get carbonated beverages? We force carbon dioxide into a liquid and we carbonate it, all right? That's what we're going to do here, something similar, okay? So when we're talking about Henry's law here, we're going to deal with solubility, how well we can get a substance to dissolve into a solution. And that's what solubility is. How well we can get a gas to dissolve into the liquid. And there's 2 things that affect that. Okay, one, our partial pressure. All right, we already know that. Okay, partial pressure, we just learned what a partial pressure was. And then what we call the solubility coefficient. And that just means how well, all right, that gas can move into the liquid. Okay? So the big part of when we're trying to get our respiratory oxygen gas into our blood is going to be the partial pressure. That's the main driving force. All right? So we saw on that previous slide, all right, that you have 104 millimeters of mercury in the alveolus, all right, but it's a partial pressure of oxygen. But in the pulmonary capillary, the partial pressure of oxygen was 40. That's a big gradient there. Okay, so that big gradient is going to be, all right, our driving force here. Okay, so that's going to help us to determine, all right, that pressure there, and also how much of the gas is going to be present there. Okay, so our partial pressure plays a big role in that. All right, when we get to the solubility coefficient, and again, a lot of this is going to depend on, all right, the temperature, obviously. All right, you heat things up, you can get more stuff to occur. You slow things down by cooling them down, all right? It's going to kind of slow the whole process down, all right? So we're going to see, all right, when we talk about the solubility coefficient, that's basically telling us how well, all right, a substance, all right, in this case, a gas, how well it's going to be able to move into a solution. So if you have a high solubility coefficient, then it's going to move. It's going to become soluble quite easily. All right. If you have a low coefficient, it's crap. And I'll show you, for example, here. All right. When we talk about carbon dioxide, look, carbon dioxide, 24 times as soluble as oxygen. What does that mean? That means that carbon dioxide can go into a liquid much easier. than oxygen. That's why we use carbon dioxide to carbonate drinks. All right? Nitrogen, not so much. It's only half as soluble as oxygen. Okay? Which is an important part, because have you ever heard of the bends? Has anyone ever gone diving before? All right? And so, you know, they say if you go down, you have to come up very slow. Because as you start to, and there's a slide on here, I'll talk about it in a second. As you start to go deeper down, you know how if you ever dove to the bottom of a pool, your head starts to hurt? Okay, that's from the water pressure. And that's only what, 12 feet, 10 feet? All right? Imagine going down 100 feet. Okay, so you're going down 100 feet or whatever. All right, what has happened is the nitrogen, okay, from your, that was a gas, all right, is driven into your tissues. Okay, so because of that increased pressure, when you start to come up, the pressure decreases, that nitrogen wants to come out. If it comes out too quickly, it causes problems, causes the bends, which it can be in some cases. I was going to just say if you've ever saw a movie, but I don't want you guys to criticize me in my movie watching. All right. But there was a movie called The Abyss. It was a James Cameron movie. And anyways, there was a character that was a Navy SEAL that they had to go down to the ocean floor, and he got a case of the bends. And in extreme cases, it can cause mental instability. All right. So I think they kind of dramatized that a little bit too much. Okay. So when we're dealing with gases that have a low solubility, they need more pressure, okay? Larger pressure gradients to get that gas into the liquid. Because isn't that what we're trying to do, y'all? When you're breathing in air from this room, we got to get that oxygen into the blood to get it to the tissues. That's what we're doing. That's what we're trying to do here. So that's what we're talking about when we talk about the chemical principles of gas exchange. All right, we've got to get that oxygen into that solution, okay? And to do that, it depends on the partial pressure of that gas and the solubility coefficient, okay? That's Henry's law. Questions about that? All right, here we go, the bends. All right, so this is what happens, all right? So that's that nitrogen gas, all right? It gets forced into the blood as you decrease, or I should say decrease, as you descend, as you go down into the ocean, and that pressure builds up, all right? And then in some cases, it can get forced into the tissues and cause damage in that situation. That's why one of the reasons, one of the treatment modalities for the bends is they put you in a hyperbaric chamber, and they leave you in there for a while. Because of oxygen, it has a better coefficient. Its solubility coefficient is better than nitrogen's. So if we blast your body with pure oxygen, all right, it allows the nitrogen that's gone into your tissues and into your blood to come out slower. And that's the whole purpose. I read an article. I was really mad about this because it's one of those websites where if you want to continue reading this article, pay this price kind of thing. And that makes me so mad because it was a good article. It was about how we've discovered the fountain of youth. And it basically talked about two things. One was the hyperbaric oxygen chamber, right? I was like, well, Michael Jackson was doing it. Why can't I? You know, I want to find out what the secret is. But it also had to do with telomeres. Is anyone familiar with telomeres? If you're into genetics, right? Telomeres are like the garbage ends of your chromosomes. And every time the cell reproduces, it clips off just a little bit more of the telomeres. And they found that the length of the telomeres, the longer they are, the longer that you'll live. And if you can somehow preserve the length of the telomeres, every time those cells reproduce, it'll pretty much be the exact same type of cell. That's the theory, at least. So that's what I was hoping the article was going to get to. I don't know. Yeah, there's an enzyme that just clips it off. So, I mean, it's cool. That's what I'm saying. I didn't get a chance to read the articles. They wanted my money. And I have a feeling if I paid the money, it was going to be like watching an ending to a bad movie. You're like, oh, man. Right. So keep that in mind. Hyperbaric chambers, that's how we're going to treat the bends. Okay.
With hyperbaric, so sometimes we'll send our patients that have trouble with lymph home to the hyperbaric chamber, like the lymph center. And sometimes they use hyperbaric chambers to like help with lymph healing.
Yep.
What is that?
That's a great question. I love that question. The reason why they do that is because when you're going to provide them with just pretty much pure oxygen, you are going to increase the wound healing capability of that tissue by providing it with oxygen for ATP production. It's the basic, I mean, that same premise is used by a lot of physicians that are involved with high-powered lasers, like you've probably heard of cold lasers and whatnot. And what it does is it keeps that oxygen cycling in there, so the mitochondria have plenty. Now we're going to start to deal with the cyclic acid cycle and the electron transport chain. But what that does is that allows that production of ATP amongst other enzymes to just pretty much promote that wound healing. Yep. It's cool. It's a cool idea. I love it. Okay. So let's go and talk about, now we're going to get into detail of pretty much everything that I just talked to you about. Okay. So we're going to start off with what we call the external respiration. Basically bringing air from the external environment into our lungs. Okay. Otherwise known as the alveolar gas exchange. So now we're going to talk about what I was talking about in this slide here. All right, we're going to talk about it in more detail. Okay, so some values that you want to know. All right, when we're talking about oxygen, it's partial pressure in the alveoli. And when you hear me say the lungs, I'm referring to the alveoli. Okay, so when I say partial pressure of the lungs is 104, specifically the alveoli. Okay, so that's going to be constant. Remember, we're dealing with a constant number. That's not going to change. 104, even though we know, all right, in the atmosphere of this room, it's 158, okay, in the room, okay? So it's less in the lungs. All right, then we also know that the partial pressure of oxygen in the pulmonary capillaries is 40. So it's higher in the lungs than it is in the pulmonary capillaries. So that's going to promote, all right, movement through the pressure gradient from the lungs into the blood. Can we all agree on that? We own that idea. We're good with that, I'm assuming. Yes? Okay? All right. So that's what we're going to see. We're going to see that diffusion. Because remember, oxygen, this is the beauty about oxygen. It's a small molecule. And remember, two things can move across the plasma membrane. All right? If it's small and nonpolar. So oxygen can diffuse right through the plasma membrane. Right? It can phase through, like me, if I was able to, I could walk through this wall. That's like what oxygen can do to the plasma membrane of the squamous cells, all right, that line the alveoli and that line the capillaries. It goes right through, okay? So it's going to move down its partial pressure gradient, okay? And so obviously this is going to keep happening until it has reached equilibrium, okay? And that will happen near the end of that pulmonary capillary with its connection to the alveoli. I'll show you in a picture here, okay? So we're always going to consider that partial pressure of oxygen in the lungs is going to always remain constant because why? You're breathing in fresh air all the time. Breath in, breath out, breath in, breath out, okay? All right, good so far? Cool. All right, so here we can see, I'll have to zoom in here because it's tough to see that picture. All right, same thing. So here at the beginning, all right, blood is moving this way from the left side of our screen to the right. Okay, so here's the partial pressure of oxygen, 40 millimeters of mercury. All right, so it's diffusing in because it's low here, and then it reaches equilibrium, 104. All right, near the end. We good with that? Okay, as it's passing through, oxygen just keeps flowing across until it reaches equilibrium, and then it won't. Okay. All right, so now when we're dealing with carbon dioxide, our partial pressure of carbon dioxide in the pulmonary capillaries is 45 millimeters of mercury, this value over here. All right, and so you can see, well, it's tough to see on here, but the partial pressure of carbon dioxide in the lung is 40 millimeters of mercury. Okay, so same thing. It's going to move down its partial pressure gradient. It's going to go from an area of high pressure to low pressure. And so it's going to leave the blood and it's going to go into the alveoli until we reach our equilibrium. All right, just to prove it to you, that's what we see here. Okay. 45 millimeters of mercury, 40 in the alveoli, it leaves, and then once it reaches equilibrium, 40 millimeters of mercury in the lung, 40 millimeters of mercury in the pulmonary capillary blood as it's exiting and moving away. Okay? You guys good with that? You're so smart. You're so smart. Okay, I love it. If it seems really simple, good. Then I'm doing a pretty decent job explaining it to you. Okay, so one of the many things that will make, remember, epithelium, okay, simple epithelium, one cell layer thick, all right, it's best suited for secretion, filtration, and absorption, okay, in this case it would be filtration. Another factor, okay, that plays a role in the effectiveness of filtration, okay, is going to be the surface area. We see that in our digestive system, which we'll start to study later on, all right, that the size and the surface area of the digestive system will maximize the absorption of the nutrients, okay? So when we talk about how efficiently we're able to have gas exchanged at the respiratory membrane, which is the simple squamous epithelium, okay, from the alveoli, and the simple squamous epithelium from the pulmonary capillary that share a fused basement membrane, all right, is a large surface area, all right, and the thinness, or this says minimal thinness, all right, that it does not have, that these gases do not have to diffuse through, all right, thick tissue, okay, that's huge. That's huge, so keep that in mind. All right, large surface area and a thin barrier or membrane, all right, makes the efficacy of this process, all right, quite good. Okay, because you have two lungs and you have 300 to 400 million alveoli per lung. Okay, it's quite a lot of surface area there. All right, check that out. 70 square meters. All right, that's big. That's like football field big. Okay, all right. So the other part when we talk about the efficacy is going to be this term here, ventilation perfusion coupling. Okay, so what's perfusion? Yeah, remember in circulation when we talked about in the circulatory system? All right, we talked about how well something can move from the capillaries into the tissue. Okay, so we're going to talk about ventilation, how well our gases can move in and out of the lungs. All right, when we talk about perfusion, we're going to deal with blood flow. Okay, so in this situation, all right, when we're talking about ventilation and perfusion, when we talk about ventilation, we're going to deal with the bronchioles. Okay, so your bronchioles, they can be in a state of constriction or dilation. All right, so if they are dilated, more air can flow in. If they're constricted, they meet more resistance, and as you know from our flow, all right, equation, flow equals the difference in the pressure gradient divided by resistance. You increase the resistance, you decrease the flow. So one way to increase the resistance is to cause bronchoconstriction. Okay? So for example, if we bronchodilate, all right, the bronchioles there, we will get an increase of carbon dioxide. All right, well, excuse me. Oops. Let me flip that. If we get an increase in carbon dioxide, all right, we're going to want to get rid of the carbon dioxide, so we're going to cause bronchodilation to get more airflow in so we can breathe off that carbon dioxide. All right, now perfusion, we're going to deal with blood vessels. As we know, blood vessels can vasoconstrict or vasodilate. All right, and again, if we have a situation in which we have decreased carbon dioxide, or if we have increased oxygen in the blood, then we're going to get dilation, all right? Because we're going to want to increase the blood flow to that area to get rid of that carbon dioxide. All right, so let me show you. Well, hold on. Hold on. I'm going to come back to that. Let me show you the picture first. And then we'll talk about emphysema. All right. So here's the ventilation here, changes in the bronchioles, okay? So we get an increased partial pressure of carbon dioxide, all right? We're going to see bronchodilation, okay? Because we want to get rid of that carbon dioxide. All right, if we have decreased carbon dioxide, because remember, carbon dioxide is going to affect our breathing rate. Remember, it's not the amount of oxygen, right? It's mainly carbon dioxide, that levels of carbon dioxide in your blood, levels of carbon dioxide dissolved in your cerebrospinal fluid, all right? And hydrogen ion concentration plays a role in that too, all right? But mainly, levels of carbon dioxide are going to affect your breathing rate and the force of your breathing, okay? So if we decrease the levels of carbon dioxide, all right, then we'll see a bronchoconstriction here, okay? Because again, carbon dioxide will help us maintain, all right, a certain pH in our blood. Now when we talk about the arterioles here, all right, if we see an increase in oxygen, all right, or a decrease in carbon dioxide, we're going to have vasodilation. We want to get that oxygen out to those tissues, all right? So we want to circulate it through, and vice versa. If we have a decreased amount of a decreased amount of oxygen and an increased amount of carbon dioxide, we're going to get our vasoconstriction here, all right? So we're going to decrease the flow until we can oxygenate our blood more and get rid of that increased carbon dioxide. All right, emphysema, what is it and why should I know about it? Okay, emphysema is actually, since you're seeing more people, I hope not as many people nowadays, with smoking, but emphysema is primarily caused, all right, with smoking. This is not a PSA. I'm not going to give you a public service announcement and tell you not to smoke. We're all adults here, all right? Just don't do it, okay? It's just bad for you. It's not good for your blood vessels either. It helps destroy elastic tissue in your blood vessels. I can go into a whole story. But I'll never forget when I was in college, I went to the infirmary one time, and I was sitting there waiting to be seen by the nurse practitioner, and I was looking at this poster, and it was this woman sitting there, and it looked like someone took, a bucket of black tar and just poured it all over her. She had like all these boils, and she looked awful. And it said, "Would you smoke if your outside looked like your insides?" This is back in the 90s. It was a pretty graphic poster. But anyways, I was like, that's pretty powerful. All right, anyways, so emphysema, okay? We're going to see with emphysema, all right, one, a problem with the destruction of the elastic fibers, okay? Remember, the elastic fibers help, all right, to get those alveoli, once they're inflated, back to their original size, okay? So if we start to decrease that, all right, then they can't return back to their original size, and we can't clear as much oxygen, as much air out of our lungs, all right? One, there's a problem with this because it's irreversible, okay? And now we've just lost a huge area for respiratory gas exchange, okay? So that's bad, all right? Not only that, all right, emphysema is an inflammatory disease, okay? And when it causes inflammation, you're going to get bronchoconstriction, and that's bad, especially when we're dealing with the terminal bronchioles, because now we're going to decrease the amount of airflow in and out of our respiratory portion of our lungs, and that ain't good, okay? So overall, we start to see a loss of alveoli. So guess what we're doing? We're increasing our physiological dead space. That's what emphysema is going to do. All right? That means you're going to have a smaller vital capacity. All right? And which is the total amount of air that can move in and out, all right, when you're taking breaths, deep breaths. But you'll also see your tidal volume decreases. So when your tidal volume decreases, all right, and you're not able to get as much gas exchange going on, what do you think? Your medullary respiratory center is going to kick in, and it's going to increase your breathing rate, and it's going to cause you to recruit accessory muscles so you can get deeper breaths. So these people have to take deeper breaths. What'd you say, trach? Oh. So you've seen an emphysema patient. Yeah, emphysema patients have thick necks because of the scaling muscles and the SCM. Remember, those are accessory muscles. So the scalenes have to start operating because they have to help lift up, all right, the upper ribs. Not only that, they're also described as barrel-chested, all right, because they have to, because their compliance decreases, so their actual chest doesn't move up and out. Those ribs don't move up and out as well as they used to. So of course we're recruiting every possible accessory muscle that we can think of to help move those ribs. Whereas you and I, just our diaphragm and our external intercostal is enough to change that thoracic cavity. Well, that's not good enough for them. They have to recruit all these accessory muscles just to try to breathe almost half as well as we can. That's why a lot of those patients near the end, they have to be on pure oxygen. So a good friend of mine has it. He smoked like a chimney though. He's from Ireland, hard-working man all his life, and he smoked all the time, and he used acid in his job. His job was to go into the brewery and spray out the inside of those big tanks where they hold the beer, and with very dangerous acid. And he wouldn't wear his respirator in there, so that probably screwed up his lungs too. It's not good. All right. Almost done, y'all. All right. So, a couple other issues when we're talking about our conditions, when we're talking about our respiratory gas exchange here. All right. So keep in mind when we're dealing with that external, all right, we're still talking about that external respiration. All of this is occurring in the lungs, in the alveoli here. All right. So again, if, for example, all right, if we decrease due to lung cancer, for example, the number of alveoli, that's going to cause, all right, a decrease in the efficacy of gas exchange. All right. Is anyone familiar with congestive heart failure? Seen it? Yeah. So it's basically right-sided heart failure. The right side of your heart decides to have an issue, and guess what? The right side of the heart is the part of the heart that sends the blood to your lungs. All right. And that causes an issue. And in this situation, when we're talking about congestive heart failure, you can see a thickening of the respiratory membrane. The heart doesn't pump out as well, and that causes a backflow of blood into the pulmonary circulation. It's not uncommon for these types of patients to cough up a pink, frothy sputum. It's kind of nasty. All right? It's because the blood is backflowing into the pulmonary circulation there, and now you're getting blood diffusing into the lungs, you know, instead of air diffusing into the lung, not air, but instead of carbon dioxide diffusing into the lungs, blood's going with it, okay? It's not pretty, okay? All right, so the basic takeaway point for all this is these diseases, all right, are going to decrease your blood, all right, partial pressure of oxygen, and it will increase the blood partial pressure of carbon dioxide. Uh-oh. Well, we talked about what happens last class with the reflexes that start kicking in. All right, when you have elevated partial pressure of carbon dioxide, all right, you're going to see, all right, your respiratory rate increase, your depth of breath will increase, all right, you're going to exhaust and use more energy, more ATP to operate that system, and most likely you're not going to have the results that you want, meaning you're not going to have oxygen levels as high as they would be in a healthy individual and have your partial pressure of carbon dioxide decrease like you would have in a healthy individual. So those folks always look tired. It's not a pretty sight. Okay. That's a perfect place to stop, okay? We'll get into the internal respiration and finish up this chapter. What's today? Wednesday? Next week. Let's take a break. Let's meet back here. It's quarter after. Yeah, let's meet back here at 7:30. Okay? Give it 15. Maybe we can get out of here early. I know you guys hate when I do that.